Welcome to BCNephro, BC here. Today we're talking about hyponatremia. You've seen the traditional algorithm for the differential diagnosis of hyponatremia: hypovolemic, euvolemic, hypervolemic. We're not talking about that today. Today we're going for a deeper understanding of what the lab studies tell you about the patient's physiology and how that helps aid in your understanding of the condition that the patient has. First, what does the serum sodium tell you about the patient's physiology? Does it tell you about sodium, or does it tell you about water? If the answer is sodium, you're wrong. It's all about water. Hyponatremia means that there's excess water relative to sodium. The water goes into the cells via the osmotic gradient. The cells swell, and that leads to the CNS symptoms that we typically see with hyponatremia. Why do we check the serum osmolarity? Well, you measure serum osmolarity, and then you can calculate calculated osmolarity by this formula here. If the osmolar gap is elevated, then the hyponatremia may not be real. It may be pseudo-hyponatremia. If there is an elevated serum osmolarity, you're thinking about translocational hyponatremia. The next thing we're looking at is the urine osmolarity. The question is, if you're hyponatremic, how dilute should your urine be? The answer is as dilute as possible. By convention, that's urine osmolarity of less than 100 means that ADH is appropriately suppressed. If this is the case, thinking about primary polydipsia or poor solute intake, the tea and toast diet, severe protomania. If urine osmolarity is greater than 100, then ADH is present. Now you have to figure out, is that appropriate or inappropriate? Okay, so the urine osmolarity is not low. That means ADH is present. This ADH can either be appropriate or inappropriate. The main appropriate reason for ADH is osmotic stimulus. These are people who are dehydrated, hypertonic, hyponatremic. That's not the case here. We're working up hyponatremia. The other reason is hemodynamic. Patient in a state of shock, body is hanging on to water and everything it can to maintain the volume status. Inappropriate, you're thinking about SIADH. This is why we look at the urine sodium. The body is in a state where it needs to preserve water. For hemodynamic reason, it's also preserving sodium. So if the urine sodium is low, you're thinking about true volume depletion or decreased effective arterial volume in states like heart failure or cirrhosis. Now, if urine sodium is not suppressed, then there is not evidence of a hemodynamic reason. You're thinking SIADH. Why is uric acid part of the evaluation of hyponatremia? Well, it's a clue that SIADH may be present. We normally classify SIADH as euvolemic, but in actuality, there is very mild subclinical hypervolemia. In this case, the uric acid will be diluted down and maybe less than 4. So there we have it. We check the serum sodium. It's low. The patient's hyponatremic. That means there's excess intracellular water. Then we're looking at the serum osmolarity. If the osmolar gap is increased, we're thinking about pseudo-hyponatremia. The patient's hypertonic, we're thinking about translocational hyponatremia. Now we're looking at the urine osmolarity. This is telling us if there's ADH present or if ADH is absent. If ADH is present, we can figure out if it's appropriate, hemodynamic or not. That's why we're looking at the urine sodium. And then finally, we can look at the uric acid to give us an additional clue that SIADH may be present. Thanks for watching BCNephro. Until next time.